everyone. Welcome to NACFC. My name is Antoinette Gardner, and I am here with Ashley Harvey, and we are moderating today's session featuring the top 3 nursing abstracts. We encourage you to submit questions for the speakers online that will be discussed at the close of each presentation. These abstracts each explore women's issues in CF, which is particularly important as women with CF are living longer and facing many decisions and concerns about pathways to motherhood, reproduction, fertility and fertility preservation, and sexual and reproductive health. We'll start now with our first speaker, Leanne Bray from the University of Alabama at Birmingham, who's going to present Abstract 486, Exploration of Paths to Motherhood in Cystic Fibrosis. Leanne.
Thank you for your introduction. Good afternoon, everybody. My name is Leanne Bray, and I'm an assistant professor at the University of Alabama at Birmingham School of Nursing. I am very happy to come to you today with 2 of my colleagues and fellow research team members, also from the UAB School of Nursing, as part of the top 3 abstracts in Nursing Symposium. As a disclosure, this study was funded by the UAB School of Nursing Dean Scholar Award. To provide the background on our study, women with CF have reproductive anatomy capable of having biological children. However, other CF-related problems, such as thickened cervical mucus, may inhibit their fertility. We do know that the majority of women with CF desire to become mothers, but no studies to date have examined the decision-making process that women with CF go through to become mothers. So this study examined factors leading to 3 different paths to motherhood in women with CF, which included biological, with or without fertility treatments, adoption, and gestational surrogacy. To form the theory of the decision-making process, we used a grounded theory approach. Grounded theory is a qualitative research method concerned with generating a theory that is grounded in data that has been systematically collected and analyzed. We recruited 25 women with CF who were mothers, with a goal of 10 women from each path. We conducted individual interviews that were around 45 to 60 minutes long about each woman's specific path to motherhood, and then also the factors that influence her decision-making process along the way. So now I will discuss our results. This model depicts our findings after analyzing the data. However, we are in the process of sending this model out to a subset of the participants for the member checking process, just to ensure that it accurately depicts their decision-making process. So based on their feedback, edits could be made to this model prior to publication. But here we have depicted the desire for motherhood as an all-encompassing part of the decision-making process. In a few instances, the desire for motherhood was influenced by changes in health status, such as FEV1, but in most cases, the desire came first. Then, if the decision was made to pursue motherhood, there was an assessment of several factors. One, significant other. Was she in a relationship? And if so, they may move to consider genetic testing for the significant other to determine carrier status for CF. Also, overall health. So can she and her partner conceive a child given her current health status? Next, finances. So what path to motherhood best fits with she and her partner's current financial status? Are there insurance or financial concerns surrounding fertility treatments, surrogacy, or adoption? And then also personal preference, which included personal values. So how did she and her partner want to grow their family, and what were their specific preferences related to that? So an assessment of these 4 factors led to a decision for motherhood, whether biologically, through adoption, or through gestational surrogacy. In a few instances, individuals reported a surprise pregnancy, which bypassed the decision-making process and led directly to a biological child. When discussing their desire for motherhood, these women talked about their desire starting at an early age. One woman said, "I've always wanted to be a mom. It was something that I remember even at 11, 12, thinking, am I going to be a mom? What can I do to become a mom?" Another woman also shared, I don't think it was ever a question of if I wanted to be a mom. Ever since I was little, I always knew I wanted to have children, and I always wanted to have a lot of children. I just wanted to be a mom. Moving from the overarching desire to be a mother to beginning to assess factors that impacted their decision-making process, these women mentioned their significant other. One woman said, I got married at 22, and so we decided to just naturally try to have a child and see what happened. Another woman said, we got married in November of 2013. We had been talking the whole time about wanting to be parents and how we would go about that. Assessment of health also impacted the decision of the path to motherhood. And one woman spoke and said, then we just realized with all of my health issues, it just made more sense for me not to be the one to carry the babies. Another woman shared a different experience and added, I think the fact that my health was pretty stable, I don't think I would have pursued it if my FEV was really low or if I was having a lot of exacerbations. Next, preferences also impacted the path chosen for motherhood. One participant mentioned her preferences regarding fertility preservation and fertility treatments. I think some people just feel led to do certain things for their family, but I've just never been interested in it, talking about fertility preservation and fertility treatments. So I never really looked into it too much. Similarly, another woman mentioned, I didn't need to know anything about that because I felt like if I couldn't become pregnant on my own, then it just wasn't meant to be, and I wasn't going to go that route. Lastly, another woman spoke about preferences surrounding surrogacy. She said, no, I don't think we would have ever gone the surrogacy route. Not slamming anyone who does that, but I just don't think it would be right for our family. In discussing consideration of finances on the chosen path to motherhood, one woman said, my husband and I, when we talked and we were financially stable and happy with where we were with our careers, so we just decided to pull the trigger. Another woman mentioned, apart from the physical health, my husband and I wanted to also be sure that financially we could do it and it wouldn't be a strain on us in that way. And then finally, the decision of what path to take. One woman spoke about pursuing the adoption path. It really wasn't worth my health trying to get through this, so we pursued adoption. Another woman talked about the biological path. I seek items as much as I seek experiences, and it seemed like I should experience pregnancy. Another woman mentioned not wanting to wait on her health status and financial situation to improve to pursue the biological path and said, I'm going to wait and wait and wait, and I might not be healthy enough to carry a pregnancy. I might not have all these years with my son or daughter that I want to have. So in conclusion, we set out to identify factors that influence the decision-making process surrounding motherhood in women with CF. This is the first study to triangulate the perspectives of women with CF who have sought out the 3 different paths to motherhood, and also hopefully give them a voice to inform clinical practice to better address their needs. And with that, I can take any questions. Thank you.
Leanne, a question that we have is, did any of the respondents suggest when they would have wanted the CF care team to start this discussion with them? Of course, knowing this is a very individual decision, would there be any general recommendations?
Sure. Many talked about, the fact that it didn't really come up in clinical practice unless they brought it up themselves. When we delved a little further into that and asked, when they thought it would optimally be brought up, most said, if in and around puberty was really, overall what they responded. There was a little variation in the specific age, but it was very close to puberty.
Okay. And then on another question, based on these findings, what do you think the main ways this study might inform clinical practice for CF providers?
Sure. So we are hoping that this study will honestly contribute to clinical practice that fully supports reproductive choices and also help lay the foundation for health education that really promotes inclusion of all women, regardless of chronic illness or disability. We also hope that it will help develop clinical practice guidelines regarding the provision of care for women with CF who are considering having a baby.
Are y'all expecting to possibly expand this study to other more, other CF centers throughout the country to get a bigger perspective?
Sure, it's definitely a potential to gather a larger sample and do a multi-center type study. We have also discussed moving forward with examining how men with CF choose their path to fatherhood. And we've also discussed forming the development of a reproductive decision-making tool for adults with CF to facilitate improved reproductive outcomes.
Now, that would be very helpful, I think, for a lot of CF centers. Because I know we work with this all the time with our adult patients, so it definitely would be helpful to have some guidelines to work with that.
Absolutely.
All right. Well, Ms. Leanne, I think you had a reference slide if you wanted to show that. And
sure. There's my references.
So that we can then get ready to move on to our next speaker. And that way we can change tracks to our next speaker, who is Janet Brown, who is also from the University of Alabama. And she is going to be discussing her abstract, which is abstract 489. And it is exploring the interplay between self-efficacy and sexual and reproductive health in women with cystic fibrosis. Janet, you are now on.
Thank you. Can everyone see my PowerPoint? Hello, I am Janet Brown. I'm a PhD candidate, and thank you for that lovely introduction. I am from the UAB School of Nursing. My slide is not advancing. I do not have anything to disclose related to this presentation. To start with some background about this particular research, the overarching question for this project was a qualitative research question, and we wanted to look at what are the perceptions and experiences of women with cystic fibrosis related to sexual and reproductive healthcare services and utilization of services. So it's an overarching qualitative research question. Some background, sexual and reproductive health, or SRH, is known to be underutilized by women with cystic fibrosis. Women with CF are also less likely than members of the general population to use contraception, to receive any contraceptive counseling, to obtain pregnancy or sexually transmitted infection testing, or even to receive routine cervical screening. Self-efficacy is defined as confidence in your ability to complete a task, and this may be an important factor related to obtaining SRH or sexual reproductive health care services. So this study aims to explore these factors that may lead to decreased SRH care, decreased utilization of these services, specifically looking at this interplay of self-efficacy and SRH. This study is a qualitative arm of a concurrent mixed method study, and it's a part of a larger parent study. The parent study is sexual and reproductive health in adult women with cystic fibrosis, and 10 women who were aged 25 years or older. That was because that was the inclusion criteria for the parent study. And these women were recruited from a single CF center in the southeastern United States and were interviewed via telephone. The interviews were transcribed verbatim and then were analyzed using thematic analysis. Results from these interviews and analyzing the interview data resulted in 7 out of the 10 women described themselves as confident in relation to utilizing SRH care services. Additionally, 8 out of the 10 women reported that they did indeed receive SRH care in the last year, and those things were specific to routine GYN office visit, a pap smear, or contraceptive counseling. So they gave reports that during the past year they received at least one, if not more, of these services. Analyzing the data set of the interviews resulted in 4 predominant themes that emerged from the data set. The interviews were read and reread multiple times to immerse into the data. They were analyzed with coder agreement from the team who looked at the interviews as well. And the first of the 4 themes to emerge on this analysis is that women with cystic fibrosis are confident in their ability to bring up the topic of SRH with their healthcare team. They described this with comments like, "I'm very comfortable," when she was talking about bringing up this topic of SRH, or "I'm confident to ask my health team pretty much anything," or "I feel very comfortable speaking about any of my sexual reproductive health care," or whatever you call it, any of these topics with my CF physician. So in many ways, not limited to these 3 examples, women described confidence, and they described confidence with aspects specifically related to SRH. Additionally, in the beginning of the interview, we talked about general confidence and how self-efficacy is described as confidence, and then we narrowed it and talked more specifically related just to SRH. A second theme to emerge with analysis of this data set are the ways that confidence is obtained. And confidence they described as being obtained from talking to other women with cystic fibrosis, by successful navigation through the healthcare system to obtain their SRH services. They talked about receiving encouragement from their support system, and that might be a parent, it might be a friend, or it may be a trusted member of their CF healthcare team. Examples of this confidence and the way they described it were a woman that said, "Friends," and she was talking to her friends with cystic fibrosis, "friends gave me advice. Then I also have older sisters that definitely I always went to for advice." Another woman described this confidence by telling me, "My family said it's just normal," and she was talking about routine SRH care. "So I was just taught that you're supposed to do that." And she was explaining to me that her mother said, "This is what everyone does. This is what I do. This is what your sister does. Just," and I think she joked about it and said, "Just grow up and do this. Everybody does this." And she said, 2 months ago, I had my yearly pap smear, so this is just what you do." Another woman described it by saying, "One of the things that makes me confident is a good relationship with my team members." And she was talking about her CF healthcare team, and that her ability to have conversations with them made her feel more confident and able to navigate the system. The next thing to emerge is that women with CF overall do not feel they have adequate information due to lack of available research and education. And one of the women described it that, "I always felt like I was blindly on my own when it came to that." And she was talking to me about SRH information. Another one said to me, "The bottom line is you really don't even know when you do research online, because it's not coming from your doctor, it's not from your team." And she talked a lot about the uncertainty of online information. She talked about looking at the sources, and sometimes even with some of her some blogs that she followed, not being sure that the information was fully complete, or sometimes that the information might not be completely accurate, were the way she was explaining that to me. And then another woman said, "I think it would be easier if they had more information." So this overwhelming theme of a lack of adequate information. Some women describe this lack of information as research information that's just not quite available yet. Others talked about not receiving it as an adolescent and then receiving it later as an adult and wishing that they had received a little bit earlier. But the overall theme was inadequate information. The next thing to emerge was that the CF care team does not bring up this topic during routine visits. And this theme was prevalent through all these interviews. One participant described it to me, and she was saying, I don't know if other people are being talked to about these things. And she was talking about SRH. She said, but I can only speak from my experience. So it might be that they're talking about it. I just don't know. So her personal experience was that she had not had that topic brought up to her, but she was really open to think that other individuals at other centers or even other people at her center might be having those conversations, but she herself had not experienced that. Another one said, if I had to be honest, the only reason I could think of it coming up, she's talking about this topic of SRH, of it coming up, is maybe because pregnancy is not encouraged. Maybe that's why and she's talking about pregnancy, well, never brought up. So her impression, somehow she had received this feeling that it wasn't brought up because it was not something that was encouraged to talk about. Two other topics that did arise during looking at analyzing the themes were that barriers and facilitators exist. And these are not themes specifically toward SRH like the other themes, but they were barriers that might exist. And a barrier to having these conversations might be that our friend or depending on the age, they were talking about remembering when they were younger that a parent or a friend might be present during the clinic visit. They also talked about a barrier to receiving adequate information or pointing towards services might be that the topic is embarrassing. Some women describe this embarrassment as their own embarrassment, and some women describe this as embarrassment of different members of their team, feeling like their feeling or their impression that maybe some members of their team might not be quite as comfortable with the topic. Facilitators that they talked about were a good relationship with their team and also being very comfortable with their healthcare team. So there was someone that they would identify, and they're all different members. I recall that one woman described a respiratory therapist, one woman a social worker, one woman a physician. Really all different members of the interdisciplinary team were described by different women, and each one described some particular person they had a good relationship with and they were very comfortable with. So kind of to summarize, looking at all of the interviews, women that reported self-efficacy toward SRH, they also were the same women who reported utilizing SRH care services in the past year. Also, from other studies and from Dr. Banduro's classic research, we do know that self-efficacy toward any particular skill can be improved. So that leads to the conclusion that this is the first study that explores the interplay between both self-efficacy and utilization of SRH care services among adult women with cystic fibrosis. Also, a better understanding of the development of self-efficacy skills could guide future guidelines and could possibly lead toward interventions that would improve self-efficacy, that could improve utilization of SRH in women with CF, but more globally, it could also impact self-efficacy could impact utilization of all the aspects of CF care as well as chronic care of other conditions. Are there any questions?
So Janet, there's one question that has come up that how can nurses, nurse practitioners, and the CF care team members support women with CF specific to fertility and fertility preservation?
That is a wonderful question. And when I was reading the interviews and looking at the ways that women obtained confidence, it was by hearing the stories of other women. It was by the vicarious experiences of their friends, or it was by verbal persuasion, which was encouragement from other people. So all members of the healthcare team can share the stories, de-identified, of course. We're not going to share someone's information, but we could share information about the experiences of other ladies. We could give them verbal persuasion toward the thing that they want to do. So if they have verbalized towards that, I know that I need to have a pap smear this year, then we could provide, as any member of the interdisciplinary team, we can provide that support by encouraging them to move forward to schedule that appointment. And then also mastery experiences. So any member of the team could be the guide on the side to walk them through that first experience, and maybe to follow up with, hey, did you go to that appointment? Oh yeah, great. Your pap smear was wonderful. So that even those few words would be, helping them with that mastery experience. So it would be opportunities for any member of the health team to really support, women in this process.
There's another question that came up that, though I don't have CF, I've navigated the struggle of finding an expert clinician to treat my gynecological and pelvic health needs. How can CF patients better find clinicians that meet both their SRH and CF needs? Or how can increased communication between their CF care teams occur?
That is a wonderful question, and I wish that I had a wonderful answer for that very good question. I think the work of Dr. Lodoris, Dr. Bray, myself, and Dr. Kazimierski, I think that's what we're working toward, is finding a way to, to create some links and to lead toward interventions that would make this process better. So I'm sad to say that I don't have a nice answer for that, but I think that, as a part of a team, we're all working toward that same goal.
Okay, Janet, so what do you think the next research steps would be?
I think a next research step would be possibly an intervention study to incorporate interventions into clinic, into routine practice that would be designed to improve self-efficacy, and to see if it, number one, improves self-efficacy, and if number two, if improved self-efficacy improves utilization of services, or does it improve adherence? Does it improve, encompass it? It could even be, more global towards cystic fibrosis care, not just narrowed to. I'd like to start with SRH. I think that's a big focus, but I think that eventually it could broaden.
My other thought is our consideration of doing it with a younger age group, because I think you said it was patients over 25, and considering we need to start looking much earlier, are we looking at possibly expanding that and then to other CF centers as well?
Yes, definitely to increase the age. This was inserted into a parent study, and the parent study has a twin study, a sister study that was the younger women, and this was the older women. So definitely this would be expanded to the younger women, and then also across centers to have more generalizable information.
There's a question also about having a list of, if there's a list of GYNs throughout the areas that people may provide to their patients. That's something that is very helpful to help people if they're looking for a GYN who may be familiar with CF. That, we've looked into it already, which may lead some confidence. I know we do that at our center. We have a number of people that we know that are familiar with CF, and that can be helpful. Okay, well, Janet, thank you very much. That was a great presentation. And that leads us now to our next speaker. So our final speaker this evening, or this afternoon, wherever you are, is Sigrid Lodoris from University of Alabama in Birmingham. And her discussion is going to be abstract number 487, and fertility preservation in women with cystic fibrosis pre-lung transplant. Ms. Sigrid, please go ahead.
Afternoon, everybody, or good morning, wherever you are. My name is Sigrid Ladoris, and I'm an associate professor at the UAB School of Nursing. I'm especially thrilled to be presenting in this top 3 abstracts in the nursing category with my UAB colleagues that you've heard from, Dr. Bray and soon to be Dr. Brown. Thank you for this opportunity to share study findings related to my study on fertility preservation in women with CF pre-lung transplantation. This NIH-funded study sought to examine the state of fertility preservation counseling among women with CF pre-lung transplant from the perspectives of the patient, partner, and CF provider. This larger parent study is a 2-year mixed method study. However, this presentation here today will focus on describing results from the qualitative data obtained from the patient group. These are my disclosures. So brief background, as we know, CF is no longer a disease of childhood, and due to advances in drug therapy and clinical care, over 50% of the current CF population are over the age of 18. Individuals with CF are meeting the same developmental milestones as their non-CF peers. This includes careers, academic achievements, and even creating families. Yet women with CF have limited knowledge about the content of their reproductive health challenges, and many are dissatisfied with the timing and delivery of reproductive health-related discussions with their CF providers. For the subset of women with severe lung disease who are being evaluated for a lung transplant, there are no published studies on whether CF providers discuss fertility preservation with them. Women with CF and their partners would benefit from early discussions about fertility preservation before transplant. While we know that fertility preservation counseling is part of comprehensive care in the oncology population before they receive chemotherapy or radiation, there are no fertility preservation clinical guidelines for women with non-malignant conditions like CF. So the purpose of this study was to explore the knowledge, experiences, preferences, and concerns of women with CF regarding fertility preservation as a reproductive option pre-lung transplantation. We conducted a semi-structured interviews with adult women with CF in the United States pre-lung transplantation and who are between the ages of 18 to 35, which is the general cutoff when defining childbearing age. The interviews were audio recorded, transcribed, verbatim, and analyzed using thematic analysis. What we found was that the average age of the women who participated in the study was 28. Most of them were in long-term relationships. 6 were mothers already. And most of them reported high lung function, even though 2 were actually being evaluated for transplant. 4 major themes emerged from this qualitative data, and the first one revolves around knowledge. So the theme is women with CF express poor knowledge about fertility and fertility preservation. I'll be reading some quotes to illustrate these themes. One participant said, getting pregnant and having a kid. So it was kind of, you learn from having doctors talking to you about it, about how difficult it can be, but I haven't really come across much of it. So I guess my knowledge would be a minimum. Another woman said, I really didn't feel like there was a lot of information about fertility and CF. I felt like I was doing a lot of Googling and a lot of asking other women with CF about their experiences. And another woman reported, I made the wrong decision, but I also didn't have the education either. These are just some of the quotes that we pulled to illustrate and really make these themes come alive. The second theme revolves around experiences. So fertility is a low priority area for the CF care team. One woman said they just look at me as, okay, your lung function's this. If you're sick right now, I want to give you an antibiotic. They don't see me as somebody who wants to be a mother, somebody who wants to have a family and do all that. Another woman said, "You feel like an inconvenience." I know the women, they feel like, "Oh, whoops, I don't want to step on your toes, but I'd like to have babies. I know my lungs are okay, but can I have a kid?" It shouldn't be that way. And finally, another woman said, "I'll come in, I'll blow into the machine, you'll give me my pills, and we'll just go about our business." That's how I see my CF clinic, unfortunately. It's very transactional. Because realistically, if and when I get pregnant, they will work on my lungs and I will go and see my OBGYN for everything else. And finally, the theme of concerns came up from the narratives from these women. They reported having concerns about the lack of normalization of their desire to have a family and to regularly discuss sexual and reproductive health concerns with their CF care team. There was a time, one woman said there was a time in the day that somebody was like, "Hey, we know that you're coming of age. Hey, you just got married. Have you thought about your husband getting tested for the gene?" Like something like that, because that's a normal test that somebody runs, even if they don't have CF. So it's normalizing the CF patient, which is really all a CF patient wants, is to feel normal and for 1 second not be that CF patient. Another woman reported, "I'll say that with fertility, I feel like it comes across to everybody. Everybody has the baby maker skills." And finally, a woman said, "When you take away CF, or when you take away all of these identifiers and labels, life in itself is simply just a cycle of creation and end, creation and end. Naturally, having children is just a part of it. It's just a part of what's inevitable. We have to look at this. We have to treat it as a normal part of life." The last theme revolves around their preferences. Women with CF recommend having CF-trained reproductive or fertility specialists become part of the CF care team. And this is consistent with what we've heard so far from Dr. Bray's presentation and Ms. Brown's presentation. One woman said, "I definitely feel like fertility needs to be discussed in the clinic, and I think it needs to be a routine discussion. I feel like having an OB being present and somebody that we get to talk to for that next step would be even better." Another woman reported, "I think that it's important to have an overlap in CF care and women's health care because there's a CF body and it's different than other people. I feel like if there's a connection between the CF care team and an OBGYN, then they could share the information and work together with that." And lastly, another participant said, "Getting a CF gynecologist on the CF team, that really is important to me." In conclusion, many women of childbearing age who have CF want to become mothers. However, they lack knowledge of fertility preservation as an option. Women with CF report a lack of discussion of fertility preservation with their CF care team, who they actually view as their primary care provider. And lastly, more individuals with CF are now living into adulthood, especially because of our highly effective modulators. So CF care delivery models should include early, regular, and sensitive discussions about reproductive health, including fertility preservation as an option to create biological families in the future. Our findings can help facilitate the development of clinical guidelines for reproductive health care for women with CF. I'd like to thank my collaborators, research team, and study participants for their contributions to this work. I also want to thank the NICHD for funding this study and the NACFC for putting together a fantastic virtual conference. These are my references, and thank you very much.
Sigrid, talking about guidelines, I think that's a great next step. What things and people do you see? What do you see being involved in that, as well as the members of that type of committee in developing that?
That's a great question. And there's a variety of groups who are truly invested in CF women's health. The CF Foundation has invested time and money and expertise, for example, in developing the Cystic Fibrosis Women's Health Research Consortium that is led by leaders like Jennifer Taylor Kauser, Tracy Kazmierski, Raksha Jain. So UAB is happy to report that we participate in those multi-site studies. And that's really kind of the grassroots effort in getting some of these really important work to come up and be launched. But truly, in order to identify what these clinical guidelines should be, we need to do additional research, large-scale research. I know that Dr. Jennifer Taylor Kauser is doing more of a prospective study in looking at pregnancy outcomes in women who are on modulators, for example. All of these work are really, kind of entangled with ours. And it's such an exciting time because it really shows that there's a commitment to meeting, this drive and this need for women with CF. They're largely understudied. Their needs are largely ignored. And so it's prime time that we need to come together, clinicians, scientists, stakeholders, the women themselves. These are women totally involved in different projects that we're in because they are our key informants. And we have partners in the reproductive health arena who also partner with us in making sure that this work is really solid and it's well informed and that could meet the variety of needs of the women with CF.
Great, thank you. That's a lot of good information there. What additional steps outside what you discussed that transgender men and CF patients and clinicians should take when discussing preserving fertility, transitioning, and treating their CF?
Gosh, that's a great question. It really speaks to our current times, isn't it? Mm-hmm. That we are really looking at how do we meet the unique needs of some of these subgroups of patients, and again, who largely don't have a voice. So the transgender population, for example, we need to understand what their unique needs are first. We need to be able to have a conversation with them and identify what their top priorities are and how we can best meet them in the most culturally and sensitive ways. So for that, I think that's where it needs to start. And because we are talking about fertility preservation, this work is really relevant to perhaps the reproductive health plans, their family building. And so we need to have a champion. We need to have champions from our different groups, specifically for the transgender population, to speak up and tell us what they need and how we can best help them.
There's two questions that kind of back into each other, but did the women identify specific information that they would like to receive and the timing of receiving these resources? And along with that, it kind of goes along with how do you think we can be more empowered as a CF adult care team to assist patients who want to know more about fertility?
More great questions. So thank you for sharing these, Antoinette. So I'll answer the first question about specific information that they'd like to receive. These women that we've interviewed, they prefer to have their CF care team bring it up. While most of them did have to bring it up themselves, their preference really is to hear from the CF care team as part of their routine assessments. If they come in for their quarterly visits, they want that as part of their basic assessments, just like you would identifying if there's nutritional needs or mental health needs and things like that. They really would like the CF care team to bring it up and include it as part of their routine assessments. They wanted timely information, meaning early information, before they even get down to their FEV1s, where their lung function is teetering more towards the transplant transplant evaluation. Because what we've heard from these women is that CF can be such an unpredictable disease that one day you feel fine, and then the next day you get hit by something, a virus, a bug, and then your lung function really declines so you can't recover. But you think you have time. You think you would have time to reach out to a fertility specialist and have these conversations, talk to your CF care team about it. And what these women have told us is that they really would like to have these conversations early before they even have to go through the conversation of transplant. So they also would like, as I think echoed by Dr. Bray's presentation and Ms. Brown's presentation, they would like to have a reproductive health specialist who really is knowledgeable about CF and the nuances that CF does to the reproductive health system. So if we can make that happen, we're on track.
And I think we're going to be seeing a changing environment with the CFTR modulators, because with people who are on the modulators, hopefully being healthy, more, having a better health status and better lung status. Right now, I think we've already seen the explosion of pregnancies throughout the country in CF centers, with a lot of women becoming much more healthy and becoming pregnant. So I think that also addresses the issue of starting these conversations much earlier, because hopefully we will be gone with the day that it's difficult for, we've seen many patients who never started their periods, and it taking, years after everyone else. So that, so I really do think that's a discussion we're going to have to make sure that all of our CF centers are qualified to discuss, and maybe looking into having a OBGYN who either is on standby or is available to work with the team to get to that point.
Absolutely.
And do any of you have any other recommendations you would have in that, thought of the onset of our new modulators and how it is affecting the lives of our CF patients, how that is going to affect any of the studies that you did? So I'm opening that out to any of you.
I think it's just such an exciting time, really. And we are hearing anecdotal reports, personal reports from women and their so-called trikafta babies, and a trikafta explosion or a trikafta baby boom, whatever you want to call it. But because of these highly effective modulators, the future is really bright for these women. And yet we have to temper that with making sure that they're fully aware of the potential for getting pregnant more easily than maybe in the past. And so that means that if they don't want to have babies, that's perfectly fine. Then they need to be very much on some kind of contraception and use, safer sex to resources to make sure that they're not getting pregnant if they don't want to be. So I mean, it's really an exciting time, and we really need to study the safety of these modulators on pregnancy and breastfeeding. So I know that there are several scientists right now, groups who are studying this specific area.
Great. Well, everyone, this has been an amazing, great talk. I think y'all did a great job of addressing the issues. A couple of other questions came out in the chat, and feel free to go onto the chat to look at these. One was looking at the role of the genetic counselor in helping bridging that gap, which I think that's an excellent option for care teams to look with that. And just talking about, they did a couple of things that people were asking about was some of these things seem to be patient driven. And if you have a fertility specialist as part of your team, how do you find the support? So those are all questions to consider for everyone. So I want to thank all of you for presenting your abstracts and for being part of the NACFC. And thank everyone for joining us today. And I hope you all enjoy the rest of the conference, virtually as it is. I think we're all learning how to do this. If you have specific questions, please reach out through the networking option on NACFC, and you can network and ask questions to the speakers that may not have gotten answered through this session, and enjoy the rest of the conference. Thank you, everyone.